Okay, before starting this session, one should know the basic terms utilized or used in the dermatology or elsewhere in your clinical practice and in clinical scenario. Like the most common term used are used in your clinical practices is been summarized over here. Like macule, what it is, it's a pigmented or red and fat lesion on the skin. Papule is the dome-shaped surface elevation, which is 0.5 centimeter diameter. The size matter. You should know about the size. A good practitioner should know what's the difference between the macule and the papule. Uh, plaque is a flattened, elevated area on epidermis, which is about 0.5 centimeter diameter. Plaque is very important when you are seeing the patient of psoriasis and someone giving you a history about that there's a plaque on the extensor surface of the joints or elsewhere. So on silvery scaly like structure um, lesions. So one should suspect for the psoriasis as well. Vesicle is a very important one, it's like in the herpes zoster and chickenpox. What's the difference between the bulla and the vesicle is? You should know it's about the difference is the 0.5 centimeters less than of it. It's a vesicle, and if it's more than of it, there's the vice versa, the bulla. One should know the basic structure of and the layers of the skin. Like this is the cartoonic image of the skin, shows various layers of the skin. When you are going to study or see the cases of the vesicle and the bulla, then they are placed according to the location in the layers of the skin. Uh, we will see ahead. So one should know what is stratum corneum. It's a non-nucleated outermost layer of the skin, and it's about 15 to 30 layers of cells in the stratum corneum, which plays an important protective role, like prevent against the bacteria, viruses, and the fungus from, from going into a deeper side of the layer. So this is the layer that makes the skin feel rough when it is dry. So you should know what is stratum corneum and what's the extent of this skin layer is. And the extent is up to the basal layer, and the cells are connected with each other like the keratinocytes. As in this example you can see desmosome is there. So desmosome is the intercellular junctions between these cells, so they are like cohesive in nature due to this. The bullous lesions categorize into the basically two broad categories, like according to their locations. Intraepidermal, they are the fragile one, and as the name indicates, intraepidermal means they are inside or the in the keratinocytes layer. So many type of it are included in it, but the most important for you guys and according to your syllabus is the highlighted in the red one, the pemphigus foliaceus and the pemphigus vulgaris. So these are the intraepidermal bullous lesions, and pemphigus foliaceus is located in the subcorneal region of the skin layer. So you should know the skin layers. If you don't know about the corneal region of the skin, so you can't understand and imagine where it should be. So subcorneal region is for the pemphigus foliaceus, and for the vulgaris it's above the basal layer, so it's the suprabasal regions, bullous regions. Second division is the bullous disease in the subepidermal regions. Okay, they are tense blister in contrast to the suprabasal one, which are fragile. They are the tense blisters and very broad list of it. So for you guys, again, the important one is bullous pemphigoid lesions and the dermatitis herpetiformis. So these two are important for you guys, and they are all like subepidermal location. So they are, as you can see in the image, the keratinocytes are above, and there's a clefting like a space, which is a cavity, and this cavity is located below the epidermal, below the epithelial surface. So it's a subepidermal region. So that's why they called us subepidermal bullous lesion. So start from the first vesicular disease, lesion, pemphigus vulgaris or fallacious. These are the group of rare, potentially fatal chronic autoimmune blistering disease. So what is important in it? It's an autoimmune blistering disease of the skin, and also it involves the oral cavity as well. So it involves the oral mucosa as well. So pemphigus has four main subtypes: the pemphigus vulgaris and the pemphigus vegetans, which is very rare variant of it, and the pemphigus foliaceus, which is a reddened variant of this pemphigus foliaceus, and the paraneoplastic pemphigus, which is due to the neoplastic lesions, and the fourth one is IgA pemphigus. Again, for you guys, pemphigus vulgaris is the most important one and is the most common form of pemphigus, and they are referred to an intraepidermal autoimmune mucocutaneous. As I said, they are involving the oral cavity and the skin, so they are mucocutaneous blistering disorders. Um, and again, they are the fragile flaccid blisters. So autoimmune, so there should be autoantibodies for this, and for what? It's against the surface of keratinocytes, and it's against the predominant antibodies directed against desmoglein, the area which involves in the cohesion of the keratinocytes. So the antibodies against the desmoglein. So due to the damage of it, the cellular cohesion is disrupted. Okay, and some of the desmoglein, there are many type of it, like the majorly the antibodies against the desmoglein 3, while some patients also have desmoglein 1. Like in the pemphigus foliaceus, the autoantibodies are directed against the desmoglein 1. Okay, so again, for some wise of it, it's an uncommon autoimmune blistering diseases resulting from loss of normal intercellular attachment within the epidermis and the squamous mucosal epithelium. Okay, and the paraneoplastic pemphigus is associated with the internal malignancy. So the antibodies involved in it is IgG antibodies against the intercellular attachment sites, which is desmosome, as described in the cartoonic image as well. The clinical findings of pemphigus vulgaris, though they're not the part of this domain session, but let me summarize of it. These are vesicles and bulli develop on the skin and oral mucosa. They are intraepithelial vesicle located above the basal layer. The blister is basilar within the epidermis. These are all the repetitions, and if the cells are unattached within the bulla due to the antibodies against of the desmosome, so there's acantholytic cells which are mentioned in the arrow. Okay, means non-cellular, non-cohesion, non-cohesive cells spread dispersely. So this should be noted in the image as well, mentioned highlighted at the pointed arrow. Like in this image, the oral mucosa is affected, and it's presenting as a extensive erosions on the oral cavity. The patient frequently present with oral disease as the initial manifestation for the pemphigus vulgaris, and on the image on the right shows the top of the head presenting as extensive erosions with rare small flaccid vesicles around of it, and majorly at the back of the scalp. There's a clinical sign for the clinical practitioner like Nikolsky sign. If you slide uh, uh, pressure this a lesion with slight finger pressure, the skin wrinkles, slides laterally and separates from the dermis, like linear row of intact basal cells resembling a row of tombstones, and the acantholysis of keratinocytes is present in the vesical fluid. Positive Nikolsky sign is like outer epidermis separates from the basal layer with minimal pressure. So this is Nikolsky sign, as you can see in the image as well. It's a pemphigus foliaceus, like the typical blister, which is more superficial as compared as you've seen in the previous image. It's more superficial than those seen in the pemphigus vulgaris. And on the right side, there's a microscopic image shows a subcorneal blister, and the region involved is subcorneal, and there's a cavity you can see easily appreciated. It's between the subcorneal regions and the epithelial keratinocytes. So this is subcorneal blister, and this is for the pemphigus foliaceus. The diagnosis of pemphigus vulgaris should be suspected when the patient is present to you with the oral lesions and the flaccid bully on the skin. Specific laboratory tests and histology of and IMF testing has been done for the skin biopsy specimen, which can establish the diagnosis. Autoantibodies can be detected in the serum by IMF, immunofluorescence assays, and the skin biopsy reveals intraepidermal bullar formation, and also called acantholysis, means loss of cell adhesion between the epidermal cells, as also mentioned in the microscopic image in the previous slides. And if you are using direct and indirect immunofluorescence stains or studies for these lesions, so the perilesional shows deposit of antibody, which is IgG, and the complement C3 in the epidermal layer of the skin, means the desmosomal area, or against the desmoglein. About the treatment of it, yes, there's a few lines of treatment, like the first line and the second line. So let's go it for quickly. Like for localized disease, topical steroids may be effective, and for generalized disease, prednisone is the mainstay of therapy and often works uh, to stop this blistering. The initial dose of prednisolone, one should know, is usually for many of the cases that drug dosage is 1 milligram per kg per day. And you should know one thing about the steroid use is that, being a good practitioner, when you are initiated the steroid, please, when you are going to stop it on gradually basis, means like tapered over weeks. Okay. And again, many of it, like the steroid sparing immunosuppressive therapies, and second line of drug as well for the severe cases, like using of the immunosuppressants, anti-inflammatory chemotherapeutic agents XYZ, which is not the domain of this, but we can quickly review it. Like the dapsone, 50 milligram to 200 milligram daily can be given for these pemphigus cases. One thing should be noted, one should be realized that mothers which are with the pemphigus vulgaris may transfer their antibodies, which is IgG, across the placenta, resulting in neonatal pemphigus vulgaris. But don't be worried about it. It is spontaneous resolves over weeks to months after delivery. These are the clinical parts one should know about the basic lesions of the skin as a good registered medical practitioner. So let's talk about the bullous pemphigoid. Uh, in contrast to the pemphigus vulgaris and the foliaceus, which are supra or intraepidermal distal lesions, the bullous pemphigoids are lesions are autoimmune subepidermal distal disease, and that is most commonly seen in the elderly age or the old age. This is also an autoimmune bullous disease, and the causes as they are again as it is autoimmune, so there should be an antibody for it, which works against of it, and same is the case, IgG antibody is there, and the complement is C3, but it is against something different from the previous one. The antibodies is against the basement membrane zone, so that's why the bullous lesion is subepidermal bullous lesion. So many causes are also in it other than of it, like drug-induced pemphigoid, though they are rare. When someone is taking a caprotein or penicillin and sulfasalazine for the psoriasis case, I think, and the furosemide, which is diuretic, they can cause. sensitive reaction, and patient present to you as a plus pemphigoid. So basically, it starts as a eczematous urticarial lesion involving mostly at the lower extremities, which is the most common site for it. And they require week and several months to develop blisters. The anatomical distribution of these lesions are flexor surface of the arms, legs, and the axilla, and or the lower abdomen. The head and neck are generally spared in this disease. So this is the discriminating point, that the head and neck are generally spared in bullous pemphigoid. The If you examine this physically, the blister is 0.5 centimeter, 2 centimeter in diameter, and it contains clear or bloody fluid. Um, Diagnostic test about it: skin biopsy, staining with the hemotoxin and eosin, which is known as HNE in the easy term, reveals subepidermal blisters, and you can do direct and indirect immunofluorescence studies or stains can be done for these type of cases to confirm the diagnosis, like the detect the presence of IgG antibody and the C3 immune complex against the basement membrane zone. Okay. As said in the previous slide, bullous lesions may take about weeks to months to develop a blister lesion for this type of bullous pemphigoid. So initially, a Tikari lesion is there, inflammatory plaque can appear before bulla formation. So this is an elderly man demonstrate both type of lesions, like severe bullous pemphigoid with numerous tense blisters on the lower leg on the right side of the image, a common site for the lesions of the bullous pemphigoid. This is the microscopy of the subepidermal vesicle with an eosinophilic rich inflammatory infiltrate, and as you can see, there's a vesicle which is located at the subepidermal region. You are using direct immunofluorescent study for these type of cases, then the perilesional skin area should be uh, taken, should be for the biopsy, and the perilesional skin in bullous pemphigoid shows a strong linear band of IgG directed against the basement membrane zone, as very clearly visible in this image. This is the immunofluorescence study which can use in it. So one thing one should remember is the antibodies to the basement membrane zones are detected in the serum as well, which is about 70% of the cases in the bullous pemphigoid. Again, let's go for the treatment of this case. The treatment of bullous pemphigoids involve depend on the degree of the involvement of the lesion. Again, topical steroids in general have been used in most of the cases of the dermatology. I've seen that the treatment is only mostly is steroid based. So very easy. If you want to be a easy practicing doctor, then must may consider be like a dermatologist. So, topical steroids can be given in these bullous pemphigoid regions. Systemic corticosteroids can be given for the more advanced cases. And the second line of treatment go for the severe cases. If the first line treatment not works, then go for the second and even third one. The third line is involving depth zone as well, same as the case as is the previous one, the pemphigus. So you see the treatment is more or less like the same for both type of the cases, but the thing is to diagnose the case, and it requires the immunofluorescence for confirmation of the diagnosis. Another subepidermal lesion or bullous lesion, location subepidermal dermatitis herpetiformis. It's a chronic pruritic vesicular disease characterized by the symmetrical group of vesicles on the elbow. The key location. The location in the skin disease always matter. Like the bullous pemphigoid spare the head and neck region and face region and about this, it's most likely involve the elbow region in the dermatitis herpetiformis. Again, the antibodies involved in it: IgA, anti-IgA complexes, type 3 hypersensitive reaction in it. In this case, deposit at the tip of the dermal papillae. So in this case, IgA anti-IgA complex of type 3 hypersensitive reaction deposited at the tip of the dermal papillae. Okay. So the question is very important in this, which will be asked frequently on many occasions. The type of hypersensitive reactions involved in dermatitis herpetiformis. This is type 3 hypersensitive reaction, antigen antibody complex, as you know. So subepidermal vesicles contain neutrophils in it, and the other important part is the vesicle contain the neutrophils. Okay, and again, one and most important thing for the clinical practice as well, it is strongly correlated with the celiac disease. Okay, and so there are anti-reticulin, anti-endomycin antibodies are present, which are also be, positive in the celiac disease cases. So dermatitis herpetiformis showing vesicles lesions with reddened on the extensor surface of the forearm. Presence of these lesions has a strong association with underlying celiac disease. So if you go for the skin biopsy of the lesion, the skin shows on the histologic examination characteristically shows the subepidermal blister with neutrophils in the blister cavity. Okay, though this is not specific for this, as nothing is 100% specific in medicine field. So, but the thing is that the subepidermal blister with neutrophils in the blister cavity and a skin biopsy of an involved perilesionous skin should be taken for direct IMF. This is very important. If you are in a clinical setup and posted as a in the setup in the department like for biopsy department, and the patient the doctor advise you to for going for the skin biopsy of the patient and it requesting a IMF immunofluorescence, though you should not take the lesional area. uh, if it's for the IMF purpose, so take perilesional skin biopsy. Okay, so this is important. So diagnosis is confirmed by the granular or fibrillary IgA deposit as mentioned in the image, and where they are deposited along the subepidermal basement membrane as shown in the figure. So biopsies should be taken from the adjacent normal skin because the diagnosis Ig deposits are usually destroyed by the blistering process. And the circulated antibodies include IgA anti-endomycin antibody, IgA anti-gliadin antibodies, IgA reticulin antibodies. If you recall this, and if you go through the GIT chapter of the pathology, then you know what are they. They are doing normally for diagnosis for the confirmation of the celiac disease. IgA anti-endomycin antibody, IgA anti-gliadin antibodies. So you should know this. So what are they? Okay, about the treatment of it, so as these are associated with the celiac disease, so adherence to a gluten-free diet uh, may give you a remission of this lesion. Spontaneous remission of this lesion is in patient on normal diet can occur, but it's less as compared to the those who strictly using gluten-free diets. The second line of therapy is this using systemic corticosteroids. Again, steroids is there, and so okay. The third point is of this lesion is that dermatitis herpetiformis is strongly associated with gluten-sensitive enteropathy. Okay, and it's associated with the celiac disease, and the antibodies mentioned circulating antibodies like anti-endomycial, IgA anti-gliadin antibodies. So these should be remembered when you are going through this topic of dermatitis herpetiformis. This is the microscopy of the DH dermatitis herpetiformis. There's a cavity, as you can see in this image. It's the blister associated with the basal cell layer injury caused by the accumulation of neutrophils, microabscesses, as you can also see in this image, at the tip of the dermal papillae. So it's associated with the IgA R2 antibodies to transglutaminase, and it's characterized by the subepidermal blister, as visible in this image. The pigmented lesions are very broad and very vast, but here we are talking about the commonest one, like the freckle, lentigo, nevus, and malignant melanoma. It's all based on your undergraduate level. Other than it, there are vast category of it. In many of the secondary diseases, this shows their signs in the form of skin pigmentation. Okay, one should be remembered that the Peutz syndrome, it shows the mucosal pigmentation in the oral cavity and in the skin as well. Neurofibroma also present with the uh, skin, and the neurofibromatosis cases, there are pigmented lesions like, if I recall, cafe olate spot, it's found in the neurofibromatosis cases. So there are many causes of it, but for you guys the important ones for the according to skin is the freckle, the lentigo, nevus, and the malignant melanoma. The freckles, also known as aphides, they are extremely common lesions that present as clusters of small, like 0.2 centimeter in diameter. They are uniformly pigmented macules. Okay, as seen in the image, as you can see in the image as well, uniformly pigmented lesions. They are directly related to the exposure to sunlight and are much more visible in summer than in winter season. They are more common and more numerous in individuals with red hair and blue eyes, and in which cases there is a probability of chance with a probability of an autosomal mode of inheritance as well. Site of predilections include the nose, the cheeks, the shoulders, and the dorsal aspect of the hands and arms. Uh, all of them are sun exposed areas. So affiliate is present as in the childhood, and they are increasing frequency in adults. Uh, they typically regress in the elderly age. So there's a predilection for the female. Physical examination, as you can see in the image, clusters of small, approximately 0.2 centimeter in diameter, uniformly pigmented macular lesions. Diagnosis, though not necessary. They are light brown, well circumscribed macules. Most commonly appear during the preschool years, and especially after the exposure of the sun. The solar lentigo, these are the hyperpigmented brown macules caused by an increase in numbers of melanocytes within sun-exposed areas. In this case, the melanocytes number are increased, and location is the areas of the skin exposed to the sun. So solar lentigos are most common in the hands and forearms and shoulders, and they are most commonly seen in the older adults as well. If compared to the freckles, the freckles have a normal number of melanocytes. Uh, okay. Another pigmented lesion is vitiligo. Vitiligo, you can for surely you see these type of cases normally around your vicinity or your area. These are the patients having the autoimmune destruction of the melanocytes. So obviously, when melanocytes are not there, so areas of depigmentation is there in your skin. They are more so commonly seen in the black population, though they are also found in the whites as well. So causes localized to extensive areas of the skin depigmentation, and vitiligo should not be confused with the albinism, okay, which is a genetic disease caused by a deficiency of tyrosinase that leads to absence of melanin synthesis and melanocytes. Okay, so vitiligo is associated with other autoimmune disease. Most of the autoimmune diseases are linked with other autoimmune disease as well, and the most common examples are the Hashimoto's thyroiditis and the hypoparathyroidism. Melasma, it's a macular hyperpigmented lesion on the forehead and cheeks, mostly seen in the women, and they are basically the melanocytes produce more melanin in this lesion by using oral contraceptives during the pregnancy and sunlight as well. Histologically, there is an increase in melanin content of the keratinocytes at all level of the epidermis. Okay, this is point. All epidermis involved increase in melanin contents of keratinocytes are seen, and there is increase in the number of epidermal melanocytes as well. Associated with the cosmetic drugs or cosmetic use, uh, sort of phototoxic drugs and vitamin A creams and the anticonvulsants, they may be associated with this melasma. Clinical manifestation, this is predilection for the face region, and if you are going through physical examination of this patient, they present as irregular light to dark brown confluent macules with sharply demarcated margins and involving the sun exposed area. Okay, diagnosis test for this thyroid stimulating hormone, microsomal thyroid antibodies test are the diagnosis test for this disease. The most common one and the important one as well, the neocellular nevus mole. These are the benign neoplastic melanocytic disorder of the neural cast-derived cells, as you know, and they are the modified melanocytes. They are mostly seen in the white people, frequently contain hairs, and they develop during the age of the infancy, like around 6 months of an age, as a junctional nevus. Physical examination, the nevi presents a variety of features depending on their stage of evolution, like junctional nevi are usually macular or slightly raised lesions around 0.5 centimeter diameter, from light brown to even black in color. They are well circumscribed, regular borders, and are usually uniformly pigmented. Uh, okay, that the compound nevus is raised, sometimes dome shaped, warty, and often still deeply pigmented. The intradermal nevus is often devoid of pigmented areas and may present as dome-shaped nodule. Malignant transformation in these intradermal lesions are rare. This is the microscopic view of the junctional type nevus. The two large areas are nested thicks of melanocytes are seen in this image, easily appreciated, though I will also make an arrow for it. It's a junction nevus. Two large areas of melanocytes expand the basal layer of the epidermis. When the nest in melanocytes in nest located at the basal area, yeah, dermal epidermal region of the skin, then this is known as junctional nevus. If they are all involving the dermis region only, then they are intradermal lesions, and if they are involving the dermobasal junction and the dermis as well, so they are known as compound nevus. Dysplastic nevus, also known as atypical nevus, they are the benign or quiet melanocytic neoplasm. Uh, Clinically, they are appears like a malignant melanoma, though they are not. Like clinically, they are showing asymmetry of the lesion, irregular borders, which are not the feature of the nevus. Uh, Multiple colors means variegated sort of appearance, and diameter of the lesion. Okay, the prevalence of the dysplastic nevus in the white population is around 2 to 10%. Those with dysplastic nevus are at increased risk for developing a malignant melanoma. So basically, these are the lesions known as atypical melanocytic lesions. They are clinically appears like a malignant melanoma, though they are not. Microscopically, they are not as weird as the name said. They first appears during puberty and may develop throughout the life, usually greater than 0.5 centimeter diameter. Again, saying variegated color, you can see pink, tan, brown, or dark brown color with an erythematous background. or irregular borders, which is suspicious for the melanoma, and they are maybe associated with the dysplastic nevus syndrome, okay, which is autodominant syndrome associated with greater than 100 nevi on the skin. Okay. Nearly everyone with this syndrome will ultimately develop malignant melanoma, though not a uh, majority of the cases are associated with the dysplastic nevus syndrome, though they are also found as sporadic cases, which don't lead to the malignant melanoma, uh, mostly in most of the cases. The dysplastic nevus syndrome, as you can see in these two images, showing the back region and the one with the back of the neck as well. There's a numerous pigmented lesions over the back and the neck. The inset shows a dysplastic look, like mole-like look. As you can see, erythematous lesion around it, variegated type of appearance, irregular uh, uh, margin. So this is suspicious for the uh, malignant melanoma, and the risk of melanoma is very high in patients with atypical mole syndrome, as said earlier, uh, with a sibling or a patient having a parent with a history of melanoma. So there's a very chance of patient to having a malignant melanoma. The presence of atypical appearance nearby in sun-protected areas in children may be a clue to the presence of atypical nevus or the mole syndrome as well. As you can see in the image, the atypical nevus larger than 0.6 centimeter around of it, with loss of symmetry, irregular borders are there, and variegation of the color with an area that is focally red. If you go for biopsy of this case, it was a severely atypical nevus. For these type of patients, the follow-up is required, periodic follow-up like 6 to 12 months with clinical examination and the photographs as well. Removal of the histopathological and the examination of any lesion with documented change is there. Also, the clinical pulse of this, as said, reputation basis, the risk of melanoma is very high in patient with atypical mole syndrome or having a patient with a history of melanoma, like in the family, sibling or parent having a history of melanoma. The presence of atypical appearance in sun-protected areas in children may be a clue to the presence of atypical nevus or mole syndrome. Again, the previous slide image, there are numerous irregular nevi on the back of a patient with dysplastic nevus syndrome. These lesions are usually greater than 0.5 cm diameter, having irregular borders and variable pigmentation as shown in the inset. On the right, there is a compound dysplastic nevus. So compound है तो इट्स मीन कि जंक्शनल एरिया पे भी निवस है, निवस सेल्स हैं और डेमिस भी इन्वॉल्व है. ओके, तो वो कंपाउंड डिस्प्लास्टिक निवस हो गया. So compound dysplastic nevus featuring a central dermal component and the asymmetrical shoulder of ascus junction malosides, as you can see in this. Or in microscopy, if actually fibrosis is also there, which is also a part of this lesion, dysplastic nevus. If you see in the dermis region, there's a fibrosis, and one thing is that you can see the vertebrae ridges are joined together. This is also a feature of it, of this disease, and involved by the nest of the atypical nevus cells, and they are in the reti of the epidermis are joined together, as seen on the right of the image, very much on the right side of the image. So this is cutaneous malignant melanoma. It's the most rapidly increasing cancer worldwide, and the more common the white as compared to the black ones, and the age is around 50 or more than of which. The risk factors for this is the exposure to the sunlight, which itself is the most important risk factor for this to develop. And the history of family member is also very important in this case, like around 8 to 10% there's a risk for it. excessive use of tanning booths and the dysplastic nervous syndrome, as mentioned previously, and like the history of a melanoma family, like persons, parents, siblings of child, or second degree relative as well, like the grandparents, grandchildren, uncles, nephews, half siblings. They are also a risk factor for this xeroderma pigmentosa and yeah, XYZ. So very good diagram in your basis showing the development of melanoma in it. As a normal skin shows only scattered melanocytes. In the B category, the lentiginous melanocytes hyperplasia seen expansion of melanocytes along the dermo-epidermal junction, as you can easily appreciate in the B. And then you see the lentiginous compound nevus with abnormal architecture and the cytokine features of dysplastic nevus cells is there. And this then progressed to a phase of melanoma in situ, yeah, melanoma in situ, which is marked by radial growth within the epidermis. And this phase is uh, often for a prolonged period. During this stage, melanoma cells do not have the capacity to invade and metastasize. With time, a vertical growth phase comes in which the tumor goes downward into the deeper dermal layer as an expansile mass lacking cellular maturation. And this regions correlates with the emergence of metastatic potential. To make it simple, what you should know is that the initiating event for melanoma to develop is the BRAF mutation, though it can also found in the benign nevus, and it is also the initiating event of this BRAF mutation leading to the melanoma, with addition to the superimposed other mutations. So it leads to a malignant melanoma, like the mutation in the TERT genes, telomerase genes, telomerase areas, and with additional mutations or epigenetic aberrations, which leads to a loss of CDKN2A, which is work as a tumor suppressor P16 gene. Okay, so the important point is that the gene involvement, the mutation involvement is the BRAF mutation, the CDAN2A gene mutation, and the TP53 mutation, which is what it is. Anyone can say it's a tumor suppressive gene. Very important one, TP53, involved in many of the cancers cases. You will see the TP53 mutation and the P10 mutation as well. So the mutation involved in these melanoma are again repetition like BRAF mutation, CDKN2A loss, TP53, which is tumor suppressor gene, and the P10 and mutation. So these are the mutations involved in the to develop a melanoma, and the tumor acquires the capacity for metastasis. Uh, these are the mutations involving the sun-exposed areas. So there are, in contrast, there are melanomas as well, which are arising in the non-sun exposed areas, like the mucosal sites. Here's the scenario is changed. The D genes, the molecules involvement is different from the one involving the sun exposed areas. The most common initiated mutation in this scenario is the gain of mutation in the KIT receptor, tyrosine kinase receptor. So, and also you can see mutation of GNAC or GNA1 in the eye melanoma, in eye cases of the melanoma. The melanoma is a skin neoplasm, a state arising from the malignant degeneration of melanocytes. It's further classified into four types majorly: the superficial spreading melanoma, which is 70%, and the nodular melanoma, lentigo maligna melanoma, and the acral lentiginous melanoma. So these four types, you should know their names, and the most common one is superficial spreading melanoma. The ABCD criteria for malignancy, like the A is for the asymmetry of the shape, B for border irregularity, C for the color variation, the D for the diameter greater than 0.6 centimeter. Go through the figures. The one which shows the gross image, you can easily appreciate the large lesions having irregular contours, variable pigmentation in this, and if it is macular areas, then it's indicate superficial growth, which is known as the radial growth. While if it is elevated areas, so it's mean that it's dermal invasion, which is known as a vertical growth, which may lead to a metastasize, as discussed earlier. The radial growth force phase with a spread of nested and single melanoma cells within the epidermis, as you can easily appreciate in the image as well. The vertical growth phase with nodular aggregates of infiltrating tumor cells within the dermis, and therefore they are typically gives you as elevated areas in the skin. The melanoma cells on histomorphological view, if you want to see under the microscope these malignant type of cells, they are having hyperchromatic nucleus, irregular nucleus of various size and shape with a prominent nucleoli. And one of the key features is the atypical mitosis, which is also in this microscopic view. I will put an arrow on it later on. Uh, After this, and in the inset, you can see there's an inset in the histomorphological view of the last slide. The inset shows a lymph node, which is central lymph node, and this is a bad lucky unlucky patient, which shows a tiny clusters of metastatic melanoma in the lymph node detected by the staining used for the menocytic markers like the HMB45 used in this case. Though there are many other markers like AS100 and MART etc. Few words about the prognosis in malignant melanoma. Unfortunately, the death rates for malignant melanoma high, and it can be cured if it early diagnosed. There you see in as in the slide that clerks determine the uh, adverse prognosis depending on the anatomical levels of the skin involved by the melanoma. As you can see in the image or slide, the level of invasions are determined from the level 1 to level 5, and it showed direct relationship with the lymph node metastasis incidence and therefore the prognosis. Few of the factors are also there, like one of the research claimed that the early age is having a favorable prognosis in the males but not in the females. Before ending this session, one thing I want to add in this, that you will see a term in some of the malignant reports, inflammatory infiltrate. Like in this case, if the dermal inflammatory infiltrate is dense around the melanoma, then it's associated with a better prognosis. Same is the case with the colon cancers in the GIT. There's a term used as the tumor infiltrating lymphocytes. If it's there, then the chances of some better prognosis there. Right. I think it's all enough for you guys. Stay blessed, stay safe, and thank you.